Hello, everyone, and welcome to the January 2025 Registry Partners Oncology Coding Break on Lymphoid Neoplasms. Today's presenter is Stephanie Gutierrez. With that, I'll pass the mic to Stephanie to get started.
So today we're going to be diving into the critical aspects of lymphoid malignancies, focusing on these objectives. We'll begin by reviewing the different types of lymphoid malignancies and their diagnosis. We'll look at additional testing that's performed on tissue to determine the correct histology. We'll review the manuals and resources needed in abstracting lymphoma. We'll go over staging and explore how to code the lymphoma SSDIs accurately. We'll review the various treatment modalities available for lymphoid malignancies. And finally, if time allows, we'll look at a case scenario together. So first, let's start off with lymphocytes. Lymphocytes are a critical component of our immune system, and they play a key role in defending the body against foreign invaders like viruses, bacteria, and even cancer cells. There's three primary types of lymphocytes, each with a distinct function. So let's break them down. First, we have B lymphocytes. These cells are produced in the bone marrow, and their primary job is to create antibodies in response to foreign substances. When B lymphocytes encounter these invaders, they secrete antibodies that bind to the foreign substances, which effectively neutralizes them and marks them for destruction. Next, we have T lymphocytes. And like those B cells, the T lymphocytes are also generated in the bone marrow, but they mature in the thymus. And they serve as direct fighters against those foreign invaders. And there's several types of T cells. So we have T cells that trigger the B cells to produce antibodies. Those are our T helper cells. And then we have cytotoxic T cells that directly attack the infected or cancerous cells. Finally, we have natural killer cells. And these cells are unique because they can destroy those foreign cells without the need of previous exposure to them. So these cells can detect and kill those infected cells, even cancer cells, in their early stages. So the lymphatic system is composed of several interconnected components, including lymph channels, vessels, lymph nodes, and various lymphatic organs that all work together. The lymphatic system carries a fluid called lymph, which contains the lymphocytes that we just discussed. And there are also several key organs that make up the lymphatic system. And we don't always think of some of these as being organs, so let's review them real quick. We have lymph nodes, the spleen, thymus, Waldeyer's ring, which is a ring of lymphatic tissue in the back of the throat that includes your tonsils and adenoids, Peyer's patches, which are clusters of lymphatic tissue that are found in the walls of the small intestine, and these help monitor and protect the digestive system. And lastly, bone marrow. So several factors can increase the risk of developing lymphoma. Lymphoma can occur at any age, but Hodgkin's lymphoma is most common in young adults and those over 55. Non-Hodgkin's lymphoma is more common in people over 60. A family history of lymphoma can also slightly increase your risk, suggesting that maybe genetics may play a role. Exposure to pesticides, herbicides, benzene, and immunosuppressive drugs that are used in organ transplants can also increase your risk of developing lymphoma. Previous exposure to radiation therapy or high levels of radiation, conditions like HIV, AIDS, autoimmune diseases, or even taking immunosuppressive drugs can increase your risk. Being overweight or obese may increase the risk of non-Hodgkin's lymphoma. And women with textured breast implants have a slightly increased risk of developing lymphoma. So it's important to note, though, that while these factors can raise the likelihood of lymphoma, many people with these risk factors won't develop the disease. Lymphoma can present with various symptoms. So here are some common ones to watch for. So lymphadenopathy. Usually these are painless lymph nodes that are swollen, usually in the neck, armpits, and groin area. A persistent fever without an obvious cause, and it can often come and go. Intense night sweats that soak through your clothing or your bed sheets. Less than 10% of your body weight lost without changes in your diet or exercise. Lethargy, which is an unusual fatigue that doesn't improve with rest. Rashes or persistent itching, or unexplained pain in areas like the chest, abdomen, and bones. So just like the risk factors we talked about, these symptoms can also be caused by other conditions. When lymphoma is suspected, a thorough workup is necessary to diagnose and treat. So first, the physician is going to review the personal and family history and perform a physical exam looking for enlarged lymph nodes. Labs will also be performed, including but not limited to a complete blood count, comprehensive metabolic panel, lactate dehydrogenase, hepatitis C, HIV testing, immunoglobulins, and serum protein electrophoresis. Imaging is also going to be obtained because they're looking for enlarged lymph nodes and possible organ involvement. If they do find enlarged lymph nodes, a biopsy will be performed. A bone marrow biopsy may also be done. If lymph nodes are suspected outside of the lymph nodes, you may see a biopsy of the other areas, such as the liver or spleen. And then we also have some special studies that we'll talk about later to help identify the histology. So when a lymph node is biopsied or removed during the workup, it's coded as a surgical and diagnostic procedure O2. Note that this is different than our normal coding instructions when we have lymph node biopsies for other cancer types and we're instructed to code them under scope of lymph node surgery. There is an exception to this rule. When you have only one lymph node that's involved by the lymphoma and it's removed, then we're instructed to code this as a surgical procedure, which would be code A250. It's also important to note that physicians usually biopsy the most accessible lymph node, and this does not mean that that lymph node should be coded as the primary site. So remember to always use the heme database and follow our rules to determine the correct primary site. Tissue exams alone are not enough to diagnose lymphoma, so when morphology and biological features help us identify the type of cell involved, we have additional tests that are needed to make that final diagnosis. So we have some chromosome testing you'll see in the chart that looks for specific antigen receptors and chromosomal translocations. Some examples of these are cytogenetics, FISH, and PCR testing. And you'll also see immunophenotyping, which identifies the cluster of differentiation markers on the cell surface. The common tests we see are flow cytometry and IHC. In the heme database, you'll find a list of that immunophenotyping markers and possible genetic mutations associated with each histology. So for example, here's a screenshot showing the immunophenotyping markers and genetic information for DLBCL. So this can be helpful to know what you're looking for in the chart. So when we're talking about lymphoma, lymphomas can be categorized into two main types. We have Hodgkin's lymphoma and non-Hodgkin's lymphoma. And this is going to be based on how the lymphoma appears under the microscope, the chromosomal features of the cells, the presence of specific proteins on the surface of cancer cells, and then for non-Hodgkin's lymphoma, the type of lymphocyte that the lymphoma originates from, such as a B cell or a T cell. Hodgkin's lymphoma is most commonly classic Hodgkin lymphoma, and then less commonly, we see nodular lymphocyte predominant lymphoma. Non-Hodgkin's and Hodgkin's lymphoma behave, spread, and respond differently to treatment. So it's important to know which one you're dealing with. So let's look closer at Hodgkin's. Hodgkin's lymphoma is primarily identified by the presence of Reed-Sternberg cells, which are large abnormal lymphocytes with multiple nuclei as seen here. These cells are the hallmark of the disease. It is most commonly affecting young adults, particularly those between ages 15 and 35, and typically originates in the lymph nodes, but can spread to other parts of the body as the disease progresses. It's generally shown an orderly spread from one lymph node chain to the next in a relatively predictable pattern. And as this disease progresses, it may involve other organs like the spleen, liver, and bone marrow. But the great news is the Hodgkin's lymphoma is one of the most curable cancers. Now let's switch over to non-Hodgkin's lymphoma. As I mentioned a few slides back, these can be grouped based on the type of lymphocyte they originated from, I won't read all of these, but I just wanted you to be aware and see some examples of the B cell and the T cell non-Hodgkin lymphomas. There are over 60 different subtypes of non-Hodgkin lymphomas, which can be classified even further into acute and chronic categories based on how they behave. So acute lymphomas are aggressive, growing and spreading quickly, and they often require immediate treatment. Despite having a shorter natural history, many patients can be cured with intensive chemo regimens. So examples of acute lymphomas are listed here. On the other hand, chronic lymphomas are indolent, growing, and spreading more slowly. These types typically have a good prognosis with a longer median survival. And here are some examples. This slide just shows the resources that we need in order to abstract a lymphoma case. So it's important that you have all the resources. We need the heme database, the hematopoietic and lymphoid neoplasm coding manual. Also note that you make sure that you are using the most current version of this manual. There was a new one that was published in November. So make sure you don't have an older one downloaded on your computer that you're using. The SSDI manual, AJCC, SEER summary stage, EOD, and then the NCCN guidelines is a great resource for treatment. Okay, so let's start with the heme database. To find the correct histology code, we're going to enter the name of the lymphoma or histology in the search box. Be sure that you check the Show Alternate Names box, which will display any other names or synonyms that might be used. And as we're talking about the heme database, I want to remind everyone that the multiple primaries calculator should only be used when the rule specifically instructs you to do so, which is Rule M15. I know it may be tempting to jump through and just go straight to the calculator, but always start with Rule M1, go through the rules in order, and stop at the first rule that applies. If you skip ahead to the calculator, this may lead to the incorrect number of primaries. Let's look at how we're going to determine histology. So once you have your working histology from the heme database, be sure you have the correct year selected based on the year of diagnosis for your case. So for this example, we have a follicular lymphoma that was diagnosed in 2023. Initially, you may have an NOS diagnosis for lymphomas, and then after those additional special studies that we just talked about, a more specific diagnosis can be made. So for example, you may have an imaging report that suggests enlarged lymph nodes, raises suspicion for lymphoma. The physician performs a biopsy, which reveals B-cell lymphoma. And then after further testing, the diagnosis might be updated to DLBCL. So once a more specific diagnosis is identified, that NOS diagnosis needs to be updated and to reflect the more specific diagnosis. Let's look at an example of how we're going to code histology. So we have a patient that underwent a biopsy of an enlarged axillary lymph node, and the path report states that the results were follicular lymphoma grade 1 to 2. So how would you code this histology? So first we're going to go to the heme database, type follicular lymphoma into the search box. Make sure you have that Show Alternate Names box checked. And you'll see that follicular lymphoma has a different histology code for grade 1, grade 2, and grade 3. But our path report says grade 1 to 2. But if you notice in the alternate names column at the bottom of the list, follicular lymphoma grade 1-2 is specifically mentioned, and we're instructed to code this to follicular lymphoma grade 2. So the answer's there, we just need to make sure we're using our manuals. Okay, let's switch over to primary site. So I know I've already mentioned this, but it's worth repeating again. Physicians often biopsy the most accessible lymph node, but do not assume the biopsy site is the primary site. We have to use our coding rules. So for instance, in the case of DLBCL, shown here, the database includes instructions highlighted in yellow that directs us to refer to the abstractor notes in Module 7 to determine the primary site. So if we look at the abstractor notes, It reads, patients may present with nodal or extranodal disease. The most common extranodal site is the GI site. Other common sites of extranodal presentation include the bone, testes, spleen, and so on. So that didn't really give us any information. So we'll go to Module 7 in the heme manual. So Module 7 starts with pH 18. So this rule instructs us that when lymphoma is described only as a mass, we should code it to the lymph nodes of that area. So an example would be a mediastinal mass. You could code to the mediastinal lymph nodes. If this rule doesn't apply, move on to the next one. So pH 19 is pretty straightforward. When only one lymph node or lymph node regions is involved, we code to that region. pH 20 provides instructions for situations when multiple lymph node chains within the same region are involved. And if you're unsure whether the chains are in the same region or not, Appendix C in the heme manual is a very helpful resource. So if you haven't visited Appendix C, make that your homework tonight to review it and look at the wonderful information that's there. pH 21 instructs us to code to C77.8 when you have multiple lymph node regions involved and we can't determine where it started. pH 22 applies to an organ and distant lymph nodes are involved, or if there's multiple organs and regional lymph nodes involved. In this case, code C77.9. Okay, just a few more rules in this list. So pH 23 instructs us to code the lymph node region when there's an extension from a lymph node into an organ. This scenario is rare, but it's important to note the primary site remains the lymph node in this situation. pH 24 directs us to code to the organ when the lymphoma is only present in that organ and there's no lymph nodes involved. pH 25 tells us to code to the organ when both the organ and its regional lymph nodes are involved. Distant sites may also be involved in these cases, but the primary site is still the organ. pH 26 instructs us to code to C42.1 when only the bone marrow or peripheral blood are involved, and there's no other sites of lymphoma involvement. pH 27 tells us to code C80.9 when there's no evidence of lymphoma in the lymph nodes, or if it originates in an organ without nodal involvement, and there's no way to identify the primary site. So let's look at an example. So this patient presents with a right neck mass. Imaging shows mediastinal lymphadenopathy, which is biopsied and positive for nodular sclerosing Hodgkin's lymphoma. Further imaging reveals the right supraclavicular lymph node, mediastinal lymph nodes, and periaortic lymph nodes are all involved. So how are we going to code this primary site? So first, we're going to go to the heme database and search nodular sclerosing Hodgkin's lymphoma. And in the orange box here, we find that lymph nodes are the usual primary site. However, there could be other sites involved. So it tells us if you have confirmation that the only involved site is something other than lymph nodes, code to that primary site. Well, that's not our case, and it refers us to see Module 7 again. So looking at Module 7 and going through the rules, we know that pH 18 doesn't apply since it's not described as a mass. So to move forward, we need to determine whether these lymph nodes are in the same region or in different regions. So this is an example where Appendix C will be helpful, and I have a few snips just from that resource here to show where these lymph nodes are located. So Appendix C tells us the mediastinal lymph nodes are in the intrathoracic region. Supraclavicular lymph nodes are in the head, neck, and face region, and periaortic lymph nodes are in the intra-abdominal region. So now we know we're looking at three very different regions. So pH 19 and 20 don't apply. pH 21 fits our case because they're from multiple regions, so we are going to code C77.8. And I know I'm going fast through this. I have a lot of slides, but you should have a copy of these slides that you can refer to later as well. Okay, let's look at another example. So this patient presents to the ED with fever and abdominal pain. Imaging reveals a large mass in the retroperitoneum, and the biopsy of that mass is positive for DLBCL. The PET shows that there's also involvement of lymph nodes on both sides of the diaphragm, pancreas, and kidneys. So this is pretty extensive. So again, to determine the primary site, we'll go to the heme database, and it instructs us to go to Module 7 for this histology. So we have lymph nodes on both sides of the diaphragm, pancreas, and kidney. So if we follow the rules, we're going to get to pH 22, where we're instructed to code C779. So sometimes you'll need to determine whether a lymphoma is a single primary or multiple primaries. So let's look at that process that's going to help guide you through this determination. So first, check if the patient has a history of a hematologic or lymphoma cancer. If yes, review the previous lymphoma's histology, diagnosis year, and primary site. Next, you're going to look at the new diagnosis and determine a working histology. Look up both of these histologies in the heme database. So it's helpful to keep two databases open if you have multiple screens that you're working with. That way they're side by side and you can refer back and forth to them. Determine if the first histology has transformed to or from the second histology. If yes, note that with a C for chronic or an A for acute. And then check if the second histology falls under the same primary section. So if it's a synonym, same primary, you would mark it with an S. So then return to the heme manual, open your multiple primary section, start with rule M1 and proceed through the rules, stopping at the first rule that applies. Be sure that you read each rule carefully because there will be terms like simultaneously and other terms that can significantly change the application of that rule if you're not careful. So some lymphomas have the ability to transform into another subtype, which can complicate this even further. But thankfully, we have rules to help guide us through these situations. Chronic indolent lymphomas have the potential to transform to more aggressive ones. And then another way of saying it is the more aggressive acute lymphoma can transform from a chronic neoplasm. So remember that when you're determining, though, the multiple or single primary, you always start with rule M1 and stop at the first rule applied. So although we do have rules for transformation starting with rule M8, sometimes you'll find that a rule before M8 applies. Rule M4, for example, tells us to code a single primary when two or more non-Hodgkin lymphomas are found in the same location. So for example, if you had a DLBCL and follicular lymphoma in a cervical lymph node, that would be a single primary. So even though those are histologies that transform to and from, you didn't make it to rule M8. So be careful, always start with rule M1 and stop at the first rule that applies. Sorry about that. So let's practice this process and look at an example. So now we have a patient who was diagnosed with MALT lymphoma of the stomach on March 5th. This patient returns September 15th and is diagnosed with DLBCL in the ascending colon. So we're going to look both of these up in the heme database, and we find out that MALT transforms to DLBCL. So we're going to label that a C for chronic. DLBCL transforms from MALT, so we're going to label that an A for acute. So from here, we're going to look through the manual and go through the M rules. Of course, we would start with rule M1, but for the sake of time, I can tell you that rule M1 through M3 do not apply. So let's look at M4. M4 tells us to abstract a single primary when two or more types of Hodgkin lymphomas are present in the same anatomical location. So this doesn't apply because we're looking at the stomach and the ascending colon. So let's move on. And again, for the sake of time, I can tell you that M5 through 7 don't apply. So we get to M8. So M8 tells us to abstract a single primary and code the acute neoplasm when both the chronic and acute are diagnosed simultaneously, which is not our case, or within 21 days, which is not our case, with only one positive biopsy. So here we have 2 biopsies, and they're more than 21 days apart. So we're going to keep moving on. I would say M9 does not apply, so we get to M10. M10 instructs to abstract multiple primaries when neoplasm is originally diagnosed as chronic, which sounds like our case, and then there's a second diagnosis of acute more than 21 days after. So this is just like our scenario. We were originally diagnosed with the chronic MALT, and more than 21 days later, the acute DLBCL. So we will prepare 2 abstracts for this patient because the rules told us it's multiple primaries. Let's move on to diagnostic confirmation. So coding this can be tricky for lymphomas, especially when additional testing like genetic tests or immunophenotyping are involved. So let's walk through this. We're going to use code 1 when the diagnosis is confirmed based on tissue alone. And tissue could be a lymph node, it could be an organ, bone marrow, or even peripheral blood. So this means that the diagnosis was confirmed with the tissue sample without any additional genetic testing or immunophenotyping. Note that peripheral blood smear is coded as 1, even though it's not tissue. I know that can confuse people sometimes. If genetic testing or immunophenotyping is performed but the results are negative, or the results use ambiguous terminology, or if it's reported as patchy weak staining, we are instructed to code 1 in this situation. So we'll only use code 3 when you have a positive histology and a positive genetic testing or immunophenotyping. And the heme database lists for each histology the diagnostic confirmation section to guide you to know whether genetic testing or immunophenotyping are required for that diagnosis. And here are some histologies, this first box. These histologies all require positive genetic testing or immunophenotyping to confirm the diagnosis. So for these, you will always have confirmation of 3. The histologies in the second box are more nonspecific, and they do not need genetic or immunophenotyping for confirmation, so they should never be coded to a 3. So this is helpful to review. Let's move on to coding lymphoma SSDIs. There are several of them. So the first one is B symptoms. B symptoms are a group of symptoms that are commonly associated with lymphoma that include unexplained fevers, drenching night sweats, and unexplained weight loss. If there's no other information available in the chart, you can rely on a physician's statement that notes a presence or absence of B symptoms. So this one's pretty straightforward. We have a 0 for no B symptoms, 1 for B symptoms, and it could be any symptoms, and then 9 for unknown. The next SSDI is HIV status. This one's pretty straightforward as well. We're going to code whether the patient has HIV or AIDS. Do not assume that the patient is negative for HIV or AIDS. So be sure you're looking for the test in the chart. If a negative HIV or AIDS test is documented, we can code that as 0. Note that we also have a note to code 1 if the patient has a history of HIV, but they're currently undetectable. And then also we can use the physician statement if that's the only information we have. If there's no information about HIV, we'll code 9 in this case. This brings us to the NCCN International Prognostic Index, IPI, which is used to define risk groups for certain lymphomas, particularly those aggressive ones. And it's based on a 0 to 5 score range. This score is determined by LDH, patient's performance status, number of extranodal sites involved, stage, and age. So always use the physician statement of the NCCN IPI when coding this field. Do not try to calculate yourself points or assign a risk. So if only points or risk are provided, document exactly as given. So notice we have codes for 0 to 8 points, but then we also have codes for if it's just stated as low risk or low intermediate risk, we have these X1, X2, X3, and X4. So if both points and risk are provided, the points have priority over the risk. This field only applies to non-Hodgkin's lymphoma, so all Hodgkin lymphomas will be coded to X9. And then I just wanted to make note too, from a quality QC standpoint, IPI is not the same thing as FLIPI. So FLIPI is specific for follicular lymphoma, and if that's all you're given in the chart, you're going to code X9 for this field. The next one is new for cases diagnosed 2025 and forward. This new one is called post-transplant lymphoproliferative disorder, PTLD, and it's a type of lymphoid proliferation that occurs in patients who've received a solid organ transplant, allogeneic bone marrow transplant, or umbilical cord blood transfusion. It's related to the immunosuppressive treatment that they receive afterwards to prevent organ rejection. So monomorphic PTLD is the most common form. If PTLD is identified along with a specific histology, such as lymphoma, plasmacytoma, and plasma cell myeloma, we're going to code 1. Classic Hodgkin lymphoma, PTLD, will be noted by the presence of Reed-Sternberg cells, and those will be coded to 2. If only the PTLD is documented without specific mention of whether it's monomorphic or Hodgkin's-like, then we have an NOS code, code 4. Also note that polymorphic PTLD is a distinct entity without an accompanying lymphoma, and that is not what we're collecting in this field, so not applicable. And then for all of your cases that are diagnosed before 1/1/2025, this field will be left blank. So for CLL and SLL, there are 5 additional SSDIs, so let's look at those. This first one is lymphocytosis. When coding lymphocytosis, it's important to use the absolute lymphocyte count, ALC, from the CBC with differential. This count reflects the number of lymphocytes in the blood. Do not use the results from a urine sample. Always ensure that the lymphocyte count is pre-treatment. If there's no documentation of this lab, you can use a physician's statement of whether lymphocytosis is present or absent, or the rise stage. And if there's conflicting information, the physician's stated rise stage will take priority. The SSDI manual also provides us a conversion if it's needed, if your results are in SI units. So we're looking for 5,000 cells per microliter, and here are some conversions you can use if yours is reported in the SI. Next, we have adenopathy. Only record adenopathy information from the physical exam. So if there's a disagreement between imaging results and the physician's statement, we always give priority to the physician's statement. In cases where the physical exam cannot be done due to the patient's obesity, you can rely on the physician's statement of peripheral adenopathy as documented on a CT. However, we're instructed to not use statements regarding retroperitoneal or mesenteric adenopathy from imaging for this field. Again, this adenopathy needs to be pre-treatment, so be sure that no treatment has been given. The next one is organomegaly. This field is recorded based on information from the physical exam, just like the last one. So both the liver and spleen must be evaluated during the physical exam in order to code 0 normal. If only one organ is evaluated in normal, we're instructed to code 9 because this indicates the full evaluation could not be completed. And like the other one, if there is a disagreement between imaging and the physician's statement, the physician statement takes priority. And if a physical exam cannot be performed due to the patient's obesity, we can use the physician statement of organomegaly based on CT results. and results must be pre-treatment. These will always be pre-treatment. Anemia is next. So for this SSDI, we're looking for hemoglobin results from the complete blood count. If there are no complete blood count results available, you can use a physician's statement of anemia or absence of anemia or rise stage as a substitute. Again, this should always be pre-treatment. And we have a conversion if needed. 11 grams per deciliter is equal to 110 grams per liter. Just to remind you in case you need to convert the results from your CBC. The last SSDI is thrombocytopenia, which refers to a low platelet count. The platelet results can be found in the CBC, and just as previously stated on one of the other ones, do not use results from urine tests for this. So if no CBC results are available, you may use physician's statement of thrombocytopenia or the rise stage. Ensure that that platelet count is pre-treatment. And again, we have some conversions for 100,000 cells per microliter in case your results are different. Okay, we made it through the SSDIs. Thanks for hanging in there, everyone. Let's switch over now to staging. So the diaphragm serves as an important reference point when assessing lymph node involvement for stage. We divide the lymph nodes into two categories: above the diaphragm and below the diaphragm. This is just a good reference slide to look at later. We won't read all of these. SEER summary stage for lymphomas is based on that nodal involvement, organ involvement, bulky disease, or disseminated disease. So for nodal involvement, we're going to be looking for mention of fixed, matted, or a mass in the areas like the hilar or mediastinum. We're looking for terms like palpable, enlarged, shoddy, or lymphadenopathy. All of these indicate nodal involvement. Localized nodal lymphomas include those where only a single lymph node region is involved. So this includes multiple chains within the same region. And again, remember to use Appendix C as a great resource for determining which lymph node region a certain chain belongs to. Localized or extranodal lymphomas include a single extralymphatic site. Moving on to summary stage 2, bulky disease refers to a large tumor mass or significant tumor burden. Regional by direct extension also includes nodal lymphomas with involvement of 2 or more lymph node regions on the same side of the diaphragm. Nodal lymphomas with contiguous extension between the extralymphatic site and the regional lymph node are also coded to 2. Also, extranodal lymphomas involving a single site and lymph nodes on the same side of the diaphragm. So not all scenarios are listed here, so be sure to refer to the summary stage manual for a complete list. But notice we're on the same side of the diaphragm. So as soon as we switch to involvement on both sides of the diaphragm, now is SEER summary stage 7. So they could either be on both sides of the diaphragm, or we could have lymph node regions above the diaphragm plus the spleen, or multifocal involvement of one extralymphatic organ site with lymph nodes, or non-contiguous extralymphatic organ involvement with lymph node involvement. Anytime that peripheral blood, bone marrow, cerebral spinal fluid, any of those involved is also going to be coded to SEER summary stage 7. So similar to summary stage, AJCC staging is based on the number of lymph nodes or organs involved in the relationship to the diaphragm. For nodal involvement for nodal lymphomas, we need to identify how many lymph node regions are involved. So AJCC page 948 lists the core nodal regions, which I've shown here in the gray box. The lymph node regions in orange, pay close attention to those. AJCC considers those 2 regions when the left and right are involved. So for example, if lymphoma is present in both the left and right cervical lymph nodes, AJCC considers this 2 regions. Conversely, if the lymphoma involves both the left and right colic lymph nodes, which are mesenteric lymph nodes, AJCC considers this only one region. So again, Appendix C is going to be helpful here. There's an asterisk next to the regions where left and right are considered separate regions. So that's helpful. I've also listed here just the extranodal and extralymphatic sites we commonly see for your reference. AJCC uses the Lugano staging system, which is a modified version of the older Ann Arbor system. So let's look quickly through these. Stage 1 includes lymphomas with only one lymph node region or organ involved. 1E is when one extralymphatic site is involved, so the E represents the extralymphatic site. Stage 2 involves two or more lymph node regions on the same side of the diaphragm. So our example from the previous slide involving both left and right cervical lymph nodes would be stage 2, since those are considered two different regions. Stage 2E includes a lymphoma with contiguous extralymphatic extension from a nodal site to on the same side of the diaphragm. If the lymphoma meets the criteria for stage 2 and is described as bulky, we'll consider that stage 2 bulky. Stage 3 is more advanced and it involves both sides of the diaphragm, either lymph node regions on both sides or the nodes above the diaphragm and the spleen are involved. And then lastly, we have stage 4. So stage 4 will include any involvement of the cerebral spinal fluid, bone marrow, liver, or multiple lung lesions. It's also important to note that most cases will only qualify for clinical staging, as a staging laparotomy is required for pathological staging per AJCC, and this is rarely performed. You may also see for Hodgkin's lymphoma an A or a B added to the stage, which will designate the presence or absence of B symptoms. So for example, a Hodgkin lymphoma that involves only one lymph node region and no B symptoms would be staged as a 1A. So treatment for lymphoma will vary depending on the histology and presence or absence of symptoms, with the ultimate goal of achieving a remission. Observation may be used for patients with indolent lymphomas that aren't experiencing symptoms at the current time, and then once symptoms arise, they may initiate treatment, such as chemo. So chemo, immunohormone, radiation, all of these could be given. I could talk for probably 3 hours just about treatment. So I just wanted you to be aware that all of these are an option. The NCCN guidelines is a great place to find additional information regarding treatment for each subtype. If you don't already use this resource, I'd highly recommend it. You will need to create a username and a password the first time you log in, but it's free. And in addition to treatment, there's a vast amount of information about each type of malignancy. It's great. Systemic therapy that's frequently given for lymphomas could be a single agent or a combination in part of a regimen. For lymphomas with high risk of returning in the tissue around the brain and spinal cord, they may be treated with a chemo injected into the spinal fluid. This is called intrathecal chemo. Another option would be to give high doses of methotrexate intravenously because this drug can pass into the spinal fluid. Hormones may be included in regimens. Be sure that if there's a hormone included in the regimen that you're coding it to the hormone, whether or not it affects the cancer cells. And then immunotherapy may be given as a form of targeted therapy. For example, if the immunophenotyping reveals CD20 is present on the surface of the lymphoma cells, Rituxan can be given, and it binds to those cells. Keytruda and Revlimid are also used to treat various lymphomas. So there are many different regimens that you'll see treating lymphomas. You make sure you're using the SEER drug RX page to help you code each drug modality appropriately. So for example, I just wanted to show RCHOP. RCHOP includes all 5 of these drugs. So it includes Rituxan, which is an immunotherapy, cyclophosphamide, which is a chemotherapy, doxorubicin, which is a chemotherapy, vincristine, which is a chemotherapy, and prednisone, which is a hormone. So for this case, we would code immuno, chemo, and hormone. Here are some other regimens. also listed here, but there are so many. Sometimes these regimens you'll see have been modified by removing one drug or possibly dose reduced because of side effects. So you can include those kind of details in your text as well. And then here's a helpful visual reminding you to code each part of the regimen courtesy of the Cancer Registry comics on Facebook and Instagram. If you haven't checked out the site yet, it's full of cancer-related comics, Cancer Registry-related comics that you might find fun and informative. Okay, we're getting near the end. Thanks for hanging on, guys. Transplant may also be part of treatment for lymphoma. Before the transplant occurs, chemo is given to destroy the patient's bone marrow cells, and then healthy cells are transfused over several hours. These transplanted cells travel to the bone marrow and begin to grow in a process called engraftment. So engraftment usually takes 2 to 4 weeks, and during that time, the patient actually stays in the hospital because their immune system is so compromised. The goal for this new immune system is to recognize the lymphoma as foreign and eliminate it. So I do want to caution you that stem cell transplant terminology may be used interchangeably with bone marrow transplant by the physicians. So it's important to determine where those stem cells are coming from, where they were harvested from, in order to code this correctly. So if the stem cells come from the bone marrow, we're going to code it as a bone marrow transplant, and we have these 3 codes. So we'll code 11 if it's from your own bone marrow, and 12 if it's from a donor, and then we have 10 if it's just a bone marrow and you don't know if it's from their own bone marrow or a donor. If the stem cells come from the peripheral blood or the umbilical cord, this is considered a stem cell transplant, and we only have one code for that one, which is 20. Also note we have a code 88, which we will use whenever a bone marrow or stem cell harvest was performed, but then for some reason the reinfusion was not performed. The last treatment we'll discuss today is CAR T. So in this procedure, the patient's own blood is taken, the T cells are removed, and then in a lab, these T cells are modified to have special receptors called chimeric antigen receptors, or CAR, that help them recognize and attach to the lymphoma cells. And then these cells are grown in millions before being reinfused back into the patient. This is a targeted treatment for lymphomas that are positive for CD19 or BCMA. This treatment has been approved for all refractory, relapsed non-Hodgkin's lymphoma, and then last year it was approved for all DLBCL and primary mediastinal B-cell lymphomas for patients under 25 years old. So since this is a targeted therapy, we're instructed to code this under immunotherapy. So this sounds like a transplant, but we're not going to code it as a transplant. You may see the drug names as well mentioned, Yescarta, Breyanzi, and Chimera in the chart. Okay, so it looks like we have a few minutes left. We can look at our case scenario. So we have a 56-year-old white female who presents to the outside hospital with 6 months history of abdominal pain, diarrhea, and weight loss. So the first thing the physicians will do is imaging, which notices a diffuse enlargement of the body and tail of the pancreas with a 2.5 centimeter ill-defined mass. Another enhancing 7.6 centimeter mass at the distal transverse colon splitic flexure with a suspicious fistulous communication with adjacent jejunal small bowel. The PET shows mildly hypermetabolic distal pancreatic mass with fistulization to the jejunum, avid peripancreatic lymph node suspicious for Mets. So they perform a colonoscopy and they take a biopsy of the splenic flexure, and the results are DLBCL. Flow cytometry is returned and it's positive for these clusters of differentiation. HIV was taken, it was negative, and the physician states the IPI is 3. The patient was initiated with treatment with Pola-R-CHOP and also consolidative radiation to the residual colon disease. So let's code this. So our histology is going to be 9680/3 for the DLBCL. Diagnostic confirmation will be 3 because we had tissue confirmation and we also had that immunophenotyping from the flow cytometry. The primary site will be C77.9 because if you had your rules in front of you, you would go through them, of course, and per rule PH22, code the primary site to C779 when it's present in multiple organs. So we have pancreas, small bowel, and colon, and regional distant lymph nodes for the involved organs. We have the intra-abdominal nodes involved. Laterality for this primary site, there is no laterality. It's not a paired site. So we'll code that to 0. Our grade is going to be 8 for lymphomas, so both clinical and pathological grade will be 8. AJCC is 4 for clinical because there is involvement of the pancreas, small bowel, colon, and those lymph nodes. Path stage, however, would be 99, no staging laparotomy. Our B symptoms is going to be 1 because we did have the 25-pound unintentional weight loss. Our HIV will be 0 because we do have that test in the chart and it was resulted as negative. The physician statement of IPI 3, we can use that. So our SSDI for IPI will be 0.3. The PTLD will be blank because this case was diagnosed prior to 2025. And then we are going to code our chemo as multiple agents, hormone, and immuno. And then here is a little more explanation for all of these fields. We've gone through these. Let's look at the next one. So chemo will be 03 because of in pola R-CHOP. When you look it up, we have cyclophosphamide, doxorubicin, and vincristine, so multiple agents. There is prednisone in this regimen, so you'll code that to hormone. For immuno, you're going to have a 1 because in this regimen there is immuno. Radiation, we are going to code that radiation to the colon. And we have all of the radiation details from that summary. And that is all I have. Thank you everyone again for having me today. I hope this is helpful.